Good afternoon, everyone, and welcome to the second session at Medical Festival Asia in our innovation track. We last week looked at healthcare delivery. Today morning's session was extremely insightful by our key opinion leaders across the board on innovation, and that the times we live in today, it is not the greatest threat, but the greatest opportunity. And to show examples and illustrate that further, we have two panelists today from across both US and India providing insights into one specific specialty as an example of this innovation that is occurring. And the session will be looking at novel models in screening for diabetic retinopathy in India and the US, in specifically close to patient contacts. Our two panelist members today, who will both be having a presentation with the Q&A after, are Dr. Anand, the co-founder and CEO of Remedio Innovative Solutions, and Mr. Steve Martin, CEO of Intelligent Retinal Imaging Systems, or IRIS, very fittingly. So I know that both of you gentlemen have a tremendous insight into innovation and have personally a strong background within the industry with a significant amount of experience, a wealth of knowledge. So I could not do it the same justice. I'll pass it over to yourselves and allow you to build out maybe some of your backgrounds and of course, your presentation. So on that note, thank you again for taking the time out for this session. I know all our attendees sincerely appreciate it. So the floor is yours.
Thanks, Varun. Thanks a lot. Appreciate the opportunity to be able to present as part of the Global Health Asia Pac conference. I think what I'll possibly do is give a quick introduction on myself and Remedio and maybe talk a little bit about what we do. So my background is as a chemical engineer and someone who's been in the in vitro diagnostics field for the past 15 years and then moved into ophthalmology in the past 10 years. At Remedio, we are looking to basically build simple to use devices that can decentralize eye testing. So that's my background, and maybe we can have Steve talk about his background as well, even as I then get my presentation on in the same time. Thanks, Steve.
Good afternoon. Thank you, Anand, and thank you, Varun, for welcoming us here today. My name is Steve Martin. I'm the Chief Executive Officer of IRIS. I don't have that technical background that Anand does, but I've spent about 25 years of my career in healthcare technology. So very excited to talk a little bit about some of the things that we're doing here in the US. And obviously we partner with Anand, so I know him well as well. Anand, I'll let you kind of take it from here.
Thanks, Steve. Just get the screen share on. Fantastic. So thank you all. So the theme of the session's novel models in screening for diabetic retinopathy. And I think the intent was to look at this from a developing world context as well as from a developed world context. And the reason why I think it's pretty fitting to think of it that way is this is a reasonably global problem, the problem of visual impairment. And we do have a significant number of people that really do not know that they may be at risk for a visual impairment. And 80% of this is completely preventable or treatable. Now, one of the normal responses that I always get is when people think of vision impairment, they usually think of the developing world, which definitely is true from the point of view of access. But if one thinks in terms of how this affects even the developed world, these possibly are three celebrities that many of you may be recognizing pretty easily. There you have Bono, who possibly would have gone blind if he did not necessarily get detected for glaucoma very early. And then you have Mila Kunik there, who has chronic iritis, and Judi Dench, who actually has been living with AMD that was detected in 2012. But each of them have a critical eye disease that they have really been able to manage to cure or control, primarily because the disease was picked up early, primarily as a result of early detection. So the key point is to say that this is as much a global problem as one may think of it as a problem of access in the developing world. Now, the reason why this is so is even though the need is huge, globally only 25% of the population actually gets screened on an annual basis. And there seem to be three key business and technical hypotheses for this. One is a certain insufficiency in the doctor-patient ratios. and that includes the US as well. Traditionally, tests for chronic and acute diseases of the eye involves getting an appointment with the ophthalmologist, invasive testing involving dilation and inconvenient wait times. And oftentimes, any attempts at being able to take these technologies outside of the specialist context, like ophthalmology or optometry, has always been difficult because these devices traditionally have been designed for specialists and not necessarily for health workers and nurses. So at Remedeo, what we are seeking to do is to disrupt this paradigm and disrupt eye care by really decentralizing eye testing. What we believe strongly in is the fact that eye testing can be decentralized to contexts where they are accessible, convenient, and affordable, and what we think will be much closer to the patient and providing options to the patient in terms of the way in which they can actually get their eyes screened. What we like to often say is build technologies that can allow anyone to screen anywhere, anytime. So towards that, a lot of the technologies that we build at Remedeo are aimed at the use of these technologies to allow for screening for a variety of the eye conditions to happen in pharmacies, supermarkets, in the convenience of a patient's home, as well as in the primary care physician office. Now, these are simple to use hardware devices, and there are two components to the technology solution. For example, this is a device that helps detect diabetic retinopathy. So it's an imaging device that takes a picture of the retina without any dilation. And there is an inbuilt artificial intelligence algorithm that is able to predict for the presence of referable diabetic retinopathy, which is integrated with the device. And this therefore enables both the ability to have the screening from an imaging perspective as well as from a decision perspective to happen at the same place. Now, while all of our devices do solve for all parts of the eye care spectrum, I think what is extremely important in the way we look at this is today's context will be, and the presentation as part of this session is going to be primarily on diabetic retinopathy. So I'll be focusing more on retinal imaging and diabetic retinopathy as part of this presentation. So diabetic retinopathy is indeed a public health challenge. 1 in 3 patients with diabetes do suffer from retinopathy. And there are close to 1 million people that are blind around the world, primarily due to diabetic retinopathy. And because of the fact that we have almost 400 million patients with diabetes around the world, it is a significant public health challenge. Now, the reason why early detection is very important is because of the fact that you could already have symptoms of retinopathy. Your vision may still be normal, but oftentimes if left undetected and untreated, it can lead to complete and permanent vision loss, which is also the reason why it's extremely important for this to be picked up early. Now, when one thinks in terms of public health challenges, diabetic retinopathy screening program has been established as something that can be done using retinal imaging and has been demonstrated to have significant public health impact. In fact, the NHS screening program in England covered almost 82% of those with diabetes. And within a period of around 6 to 7 years, they were able to show that as a result of screening done in general physician clinics, diabetic retinopathy or maculopathy is no longer the leading cause of certifiable blindness in the working age group. So what this means is there are examples of how imaging, teleophthalmology have been used in the past as a means to be able to fight the prevalence of this disease and prevent its progression leading to blindness. Now, the problem, however, that you have is when you think of what's been done at NHS and start asking the question, can this be replicated in the developing world? There are 3 key challenges that come in. One, from ecosystems where it's less about a centralized payer-led insurance model, but where most tests are done out of pocket, as is the case in possibly 95% of the developing world. Such screening needs to be extremely affordable. Secondly, if one needs to think in terms of its use by nurse practitioners in general physician clinics, the device has to be extremely simple and easy to use. And lastly, we would need to implement a similar teleophthalmology model, which means we need specialist graders as a means by which we are able to necessarily ensure that the teleophthalmology-based screening is effective in being able to identify those that need immediate treatment. Now, the problem that you have in most developing nations is all three present significant challenges because you do not have quality certified reading programs yet at scale in many of these places. Now, the way we looked at this and the changes that we brought about to build the appropriate technologies that allow us to implement this screening is a fundamental question that we asked, which is it possible for us to reduce the cost of these devices and make them much more easy to use? So what you see there is a phone-based device that allows for a nurse practitioner and healthcare worker to take a high-quality picture of the retina. And the second key challenge is to ask the question, can this be taught to someone who knows nothing about the eye, not even the biology of the eye, leave alone the mechanism by which you would image it, but do this in much shorter time than what it takes today to train someone who's an optometrist? And that's really what we did in designing the hardware device, which is to make it extremely simple to use and affordable. In order to address the problem of specialist graders, we have been using artificial intelligence as a means to be able to replace the need for specialist grading because ophthalmologists in a place like India, we have around 15 to 20,000 ophthalmologists for a total population of 1 billion. So it made a lot more sense for us to start asking the question, is it possible to look at AI as a means to be able to grade for what we call referable diabetic retinopathy? And that's really the two strategies that we took, which is a way by which we use artificial intelligence algorithms and simple to use affordable devices. Now, these obviously have been clinically validated against multiple technologies that are available in ophthalmology context, which are considered the gold standard desktop-based retinal imaging systems available from a number of companies across the globe, and which are either FDA approved or CE marked. And what we've been able to do is to show the sensitivity and specificity as well as accuracy of both the hardware as well as the artificial intelligence algorithms in multiple clinical validation studies that have been done prospectively in the field and being published in literature. In fact, one very interesting paper that we published last year was published in JAMA Ophthalmology, where we actually had a program with the government where we had youth that were unemployed that were taught how to use the device along with AI. And we compared what the predictions were from a sensitivity and specificity for detection of referable diabetic retinopathy compared to an ophthalmologist, which is the current standard of care. And that's study 3 that you see there, where the sensitivity was 100%. We didn't miss anyone that had referable diabetic retinopathy with a specificity of 88%. Now, we have scaled the hardware and the AI globally and have been able to impact so far 7.5 million patients across the world. But what I want to segue to is the kind of business models as well as delivery models that we've experimented with this device, which forms the focus of the next part of my presentation. We realized very early that if we needed to be able to reach a large number of patients with diabetes, we had to work very closely with the federal and provincial governments. So this is a model where we worked directly with 2 provincial governments, where we moved these devices to what are called district hospitals and family health clinics, where they would take an image and within 10 seconds, the artificial intelligence would say whether or not there are any changes in the retina that may be warranting a referral to an ophthalmologist. Today, we've had close to 150,000 screenings that happen per year in this context. And what was interesting is oftentimes it is not about the technology, it's about the program. So we ended up actually having to spend a lot of time ensuring that there was proper training, linked to data servers to ensure that there is a transfer in the care continuum pathway. Because screening without ensuring that those that need the attention would really not help the government achieve the goal of minimizing the incidence of blindness as a result of retinopathy. So this was one example where we actually worked very closely with the government and actually went into training and also creating snapshot databases by which monitoring could also be done by the by the district health secretaries so that they know whether or not there is an impact in a real-time basis as a result of this data being made available on their data servers real-time. Another very interesting application that we've had has been primarily in primary care clinics, where we've placed this in with WHO certified leading center for tertiary care in diabetes management, Dr. Mohan's Diabetes Specialty Center. And today they screen between 18 to 23,000 screenings per year with 22% detection rate, and 7% of those that are actually getting screened are needing immediate intervention. And if that immediate intervention was not possible, it would have actually led to blindness. And these are hub and spoke models where you actually have, using teleophthalmology, the medical retina specialists sitting in a city in the southern part of India, whereas the images actually come to that group from 45 different centers across the state. And there's a quick turnaround time by which there's a loop closure where the patient then gets the immediate information on ensuring that he or she may need a referral to an ophthalmologist to their base center. So from the perspective of a business model, this worked out very well for them because they had an ROI that was less than 1 year, but more importantly, it also helped move some of the treatment referrals to their main center where the treatment could be given. So it resulted in obviously both the revenues from treatment referrals as well as from the actual test being done in the spokes. Another interesting model has been, again, a hub and spoke model, but these are what are called vision centers. The concept of a vision center is being propagated by the well-known community eye ophthalmology center called Arvind Eye Care System, where they have a large number of vision centers that are actually run by non-optometrists, non-ophthalmologists, but public health workers and those who've actually been trained on being able to look at patients and be able to do the set of tests that you would do for screening as you would within a physician's clinic or an ophthalmologist clinic. Now, what was very interesting in this study that we did is we took a set of vision centers where we placed the cameras, and we took a set of vision centers where we did not place the cameras, because the intent was to see, are we really picking up more people that have diabetic eye disease earlier as a result of placing these devices, knowing fully well that we were getting into the ecosystem where equal number of vision centers would have the camera and those that would not have the camera. And this was something that was published recently along with the University of Michigan Ann Arbor Eye Care Center, where it was found that the number of referrals due to fundus photography findings due to diabetic retinopathy and as well as other indications of the retina was 3 times more in those centers where there was an imaging equipment versus those where you would only refer if the patient comes in and says he or she has a problem with the eye. So what this established very clearly is the fact that you do have referrals, both urgent and non-urgent referrals, that can actually be had if the program is run clearly and you're able to essentially move them to the care continuum early. Again, ensuring that at the end the patient benefits and you're able to detect the disease early. So lastly, the examples that I shared made us realize that having both the hardware and AI or the teleophthalmology was critical to scale. It allowed us a certain pricing flexibility for us to be able to scale across centers and provide an integrated product experience. And as a result of ensuring that the data was collected on servers and then made available to participating institutions where treatment was possible, the care loop closure also happened simultaneously. The advantage of accessing the data allowed us to be able to release AI algorithms post-validations on a regular basis that continued with diabetic retinopathy, and now we're in fact starting to look at other indications of the eye as well in the same centers. I think the key question that may be in everyone's mind is how do we now scale something like 7 million to 100 million? And I think the 2 key things that happened this year, this is in 2020, is we now have a lot more awareness among patients with diabetes, which has happened as a result of the ophthalmology societies in India getting into drafting guidelines for how diabetic retinopathy screening needs to be done. And this was very important because it handled a lot of questions around protocols, standardization, ensuring that at what point would you refer, how do you refer, how do you create the linkages to the care continuums. And this now has happened in the year 2020, where now we have a national task force that has created these guidelines. And we are starting to partner with the government to start looking at kiosk-based models by which we extend what has been the early success of these models to maybe ways by which we place autonomous systems in railway stations, post offices, by which we can start looking at beyond even diabetic retinopathy and start looking at eye wellness. So that's how we see this particular field evolving. The reason it's extremely interesting is it's very relevant in today's scenarios where it's going to take some time before patients may start coming to specialists for regular screenings. And therefore, these could be different ways by which either hub and spoke models or direct screening in close to patient contexts like supermarkets and pharmacies, which I'm sure there'll be a lot of examples that Steve may be able to share as well. But these are here to stay as new models by which screening can be extended and patient care can be given during these difficult times as well. So with that, I'll end, and maybe we'll have the round of questions after Steve would definitely also be presenting a lot about what has been possible in the US as well, and his examples, his challenges, and his successes that they've had as part of IRIS. So over to you, Steve.
Thank you, Anand. Let me see if I can't share my screen here. Good morning or good afternoon. Thank you very much, Anand. I think what you'll probably hear are some similar trends here in the States and some of the problems as to what we've seen. So as Anand said, diabetes, why we exist is diabetes is the leading cause of blindness here in the United States. And 95% of it is completely preventable through early detection and treatment. And so all of the quality metrics here in the United States recommend that a diabetic get an annual screen, yet less than 40% actually get it done. We think that's a matter of inconvenience. So if you think about the traditional diabetic, they're seeing their primary care physician, they're getting all of their treatment there, and right before they leave that office visit, they're being told to go get their eye screen done at an ophthalmology center. And that's where the process breaks down, because they've got to take another day off of work, get someone to drive them to and from the appointment because they're going to be dilated. And so that's really kind of where the process breaks down. So we think there's a saying here, for us to solve this problem, we have to go where the diabetics are. And in order, they're at home, they're at work, or they're going somewhere to do something. Whether that's seeing their primary care physician, perhaps they're going to a pharmacy to get their meds filled, or perhaps they're going to a lab to get an A1C. In all of those places, we believe that's a point in which we can capture the eye screen here. So we built a platform that allows an image to be uploaded, and then we have an overriding system. So let me tell you a little bit about our footprint here. Today, we have over 650 either physical locations or individuals that are mobile that provide this exam. Traditional, we're in primary care, we're in home care. We also work with health risk assessment organizations that are closing care gaps on behalf of payers. And then we have locations in lab and pharmacies. And today we do roughly 16,000 patient exams on a monthly basis. Historically, we've done 631,000 patient exams. 223,000 have been identified with some type of pathology, which I'll go into here in a minute. 125,000 of those have been diagnosed with diabetic retinopathy. And then 88,000 of them had a disease state that was sight-threatening if they didn't get help. And so that's really the whole point, is to end that preventable blindness. So we built a platform that allows anywhere to capture an image, and whether that's in a clinic setting or in the home or a lab or a pharmacy, that fundus photography is captured, it's uploaded into our platform. We enhance the image, which I'll show you in a little bit, so that the reading ophthalmologist can get a better view of the actual eye. We then have a reading center of 125 licensed ophthalmologists and retina specialists that are credentialed in all 50 states. They render an interpretation of that image, and then we return that report back to the entity that captured. And that roughly takes about 4 hours in terms of the length of how we get it back. Let me talk a little bit about the reading center here. So again, in the US, where the exam or where the exam is taking place, we need to have an ophthalmologist that's credentialed and licensed. So we've built our reading center to have coverage models based on the number of clients that we have in those states and so forth. This is an example of what an image would look like that's captured on a device here on the left-hand side. Iris takes that image and enhances it, and so we allow that ophthalmologist to look at both the original image and an enhanced image to see the different types of pathology. So one of the challenges that you'll see in when you build these ophthalmology programs, as Anand said, is you've got a varying degree of technical expertise of individuals taking these images out in the field. That's number one. Number two, as I mentioned, about a third of all our exams are done inside the home of a patient or a plan member. And that's an environment that is not standard. It can't be standardized. It's unique almost in every single one. And so lighting and other types of things can impact the quality of that image. And so historically, you see about 15 to 20% of all the images out there captured, they're not of a high enough quality where that interpreting physician can render an interpretation. So when we enhance that, we think we can increase that, and we're able to get about a 95% what we call gradability rate. And this is also, as Anand said, in an undilated environment. And so that really increases the value of that program. We then take, and then the interpreting physician can diagnose. We have an FDA clearance that allows us to diagnose the 4 stages of diabetic retinopathy, as well as macular edema. So that's mild, moderate, severe, and proliferative. Through the image, the interpreting physician can also suspect 9 other eye care pathologies, things like glaucoma, cataract, hypertensive retinopathy, wet, dry AMD, and a number of other pathologies with the eye. And we think that's critical because not only is diabetes the leading cause of blindness, but glaucoma is right behind it as well. This report is returned back to the entity. Here in the States, this is a reimbursable event by Medicare and most commercial payers. And also, as I mentioned, the reason why we think this is important is it closes care gaps. And so the US system is based a lot on quality metrics, and getting the diabetic to 100 or diabetic screen to 100% is a quality metric as well, and this qualifies for that. The reason why we think we've been successful is, first of all, to Anand's point, the technology works. The camera technology works, the platform works, and the interpreting physician does their job. The challenges that you find here in the US are all about the workflow. And so if you think about the various environments that are seeing the image capture taken, let's take primary care. Here in the States, primary care is a very hectic environment where there's a lot of patient throughput, and figuring out how to incorporate a diabetic exam in that workflow, that's really the secret sauce of making a program successful and sustainable over time. Number two, you've got to be able to integrate into the practice's system. So here, EMR, the ability to send the patient data to the camera, get that image off of the camera into the cloud, and then the report back into the EMR so we can bill for it and get proper statistical measures for the care gap qualities. Again, the technology that we use to enhance that image is really a driving factor. And then again, we have a saying here, when you've seen one workflow, you've seen one workflow. Everybody has a unique, different model. And then the last but not least is the ability to support our clients over time. Many organizations have tried to stand up some of these programs, and they think it's as simple as dropping off a camera and the images will kind of take care of themselves. That's not the case here in the US. And so we think really the secret sauce is all about the ability to design the implementation, the training, the ongoing support, and then of course the data delivery mechanisms. And if you can do those, you can have success here in the US. So I'll turn it back over to Varun and Anand, and maybe we'll have some Q&A here.
Thank you, Steve. Thank you, Anand, for those insightful presentations. It's quite amazing the work that's being done, and I don't think people realize how serious eye ailments are and the issue that you highlighted until it's quite too late or it becomes a problem. And maybe I think taking a step back, obviously the innovation is amazing, but how do you change behavior? I mean, that's quite a big question. And the reason I ask that is, I think as you're a child, or even parents will get eye screening done for their children throughout. But once you hit a certain age, teenage years, or once your eyesight stabilizes, they feel at that point, up until you get cataract at later stages of life, in between, screening completely disappears and the eyes will be perfectly healthy. How do you get screening to be continuous throughout that time so that there are early markers that can be detected?
Sure. I can possibly provide a contextual answer with our experience in India. I think the way we see behavior change happen is if the cost of actually get it done is reduced to a point where it's not seen as an investment, as an expense, but is equivalent to the willingness to pay for something else that they would actually pay for. And this was very interesting. We did this experiment where we went to malls where we started taking images. And so we wanted to understand what would be the willingness to pay when you would actually get, and what's the reason and what's the behavioral reason why they would pay us that. It was extremely interesting and insightful in the urban landscape. I wouldn't extend this to the rural landscape, but in the urban landscape, they were ready to pay what they would spend on a weekend on a movie ticket, right? So if you see, that's the equivalent. So it's about them looking at screening not initially as an investment, but as an expense. So that's what you get started off on initially. And so for it, that's one way of looking at it. The other way of looking at behavior change is when there is a disincentive for not getting it done, right? That's how at least insurance-based systems, where if the insurance allows for a certain coverage that happens as a result of someone taking care of their own health, correct? Oftentimes that disincentive of them needing to have payouts that won't come from insurance but actually comes from your pocket is the second way. Now, what we've actually seen is in the rural segment, it's more a question of access. There is people that are really wanting to get it done because eyesight is something that's very critical when it comes to most vocations that you're involved in, right? So the behavior change is more, I think, in the urban context where, of course, the change can happen as a result of getting systems closer to them. And initially it's treated as an expense rather than an investment, but over time, as insurance comes in, it then becomes an investment because it's going to be mandated then as a result of you getting covered. That's been sort of our sense on the behavior side. In the family health clinic context or the public health context, I think we've seen that the awareness has come about as a result of those places where health is viewed as a fundamental right. So in the provincial government state of Kerala, we see that the footfalls are very high because there's a high level of awareness and health is viewed as a fundamental right. It's delivered to them, right? So that's where I think eventually we all want to get to, but it's not going to necessarily get there immediately. But so you do need to see this heterogeneity of models and identify what works to change behavior in that particular context, especially because in a place like India, it's very heterogeneous. What works in place A definitely doesn't work in place B. I mean, I was sort of smiling when Steve made the point about there being one workflow. He said, yeah, it's almost the same here with its behavior is extremely different across the landscape. But these are some ways by which it can change as we move forward.
And I think, Steve, just kind of maybe asking you about, you were mentioning about the image quality, image upgrades. I think if I look at India, there is this understanding of, or this inherent bias that I have my local pharmacy, my local doctor, and I will go to my GP for everything. I think the US is slightly different. There are certain large retail stores, chain stores, pharmaceuticals. I mean, I'll give an example of, let's say, CVS or Walmart. They've got built-in audiences that really look at them as not just a retail, but possibly a pharmacy or a clinic within that, so that a screening could become a part of the shopping experience. And that kind of infrastructure is very unique to the US. In terms of, I guess, the imaging, the quality, how reliant is the solution for decentralized care? What kind of input or human touch do you need for the imaging? Or is that why your solution really helps decentralize? And what has been maybe the conversations around the infrastructure that exists very uniquely in the US to reach such a large audience?
Yeah, and if I could, Varun, I'd like to go back and just talk a little bit about the previous question, which is,
sure, of course.
You know, we were founded by a retina specialist who grew frustrated with the ability. He was seeing so many patients that they were at a point of no return where he simply could not save their sight. And he grew frustrated with that. And so he set on a course to figure out how to fix that, and that's get that early detection. And so I think, how do we change that behavior? I think the first one is education, right? Many diabetics, and the diabetic problem here in the US is not getting better. It's only going to grow larger. The awareness and the education that they need to have an annual screen. I think that there's an enormous gap there. That's number one. And diabetics are capable of managing their health, because although the diabetic eye screen is one of the lower compliant quality measures, the A1C is one of the highest, and they're both, you know, very germane to the diabetic. So that's the first thing. And then the second thing is, Anand touched on it earlier, sometimes when you have a diabetic retinopathy, there's not a lot of degradation of the vision. And so you don't know what's happening in the eyes, so you don't necessarily know that you need to go see the eye care specialist. So I think we've got to create an awareness, and I think that's starting to happen here, and the economics drive it here in the US, which is, how do I care for the entire diabetic experience? Not only A1C and insulin and having my feet checked, but making it all part of a diabetic care package. Going back to your second question.
Sorry, Steve, just before the second question, because you touched upon a really interesting point. Normally for behavior, it is a symptom that drives the screening or the treatment. And I think there's very few occasions across the medical care spectrum where you're asymptomatic, but your condition is getting worse. And the few that I can think of is usually oncology or cancer care. Obviously, the severity of that means that the disincentive is so high that you screen anyway. So there's a big behavioral shift. For eye care and in diabetic, actually, the outcome is also equally, if not critical, at least in terms of lifestyle, your lifestyle, it is a critical impact. So in terms of degradation, or how quickly it goes from asymptomatic to symptoms being too late, what is that time span? So how frequently should people do that screening?
You know, well, here's the kind of the care management protocols. And diabetic retinopathy left untreated only worsens. Once you're diagnosed with mild retinopathy, it's not like you can ever go back to no retinopathy. So you try and keep it in that state. And in the mild state, there generally doesn't have to be a lot of treatment through, maybe there's a little bit of a drug spend and it's healthy lifestyle types things. Once if you don't manage it, Then it moves to the moderate stage. And the moderate stage usually involves injections into the eyes on a monthly basis. Left untreated there, it moves into the severe and proliferative, where you're talking about surgical procedures and you are at severe risk of losing your sight. So the whole notion of this process is how to identify the ones that eventually get into the mild state and make sure I manage them and keep them in that mild state from progressing. But undetected and left untreated, it will eventually move into those states. And so I think, again, going back here in the US, it's inconvenient perhaps to go to different parts of the healthcare system. So I'm going to go get my A1C at a lab. I'm going to go see my physician, and then I have to go somewhere else to get an exam. And so bringing them into that one experience, I think, is the real key. And you had mentioned, where are we going from a retail perspective? I think some of the technology that Remitio has built, and we use the Remitio technology, and it's really helped expand that screening into a number of different locations that was not possible 2 years ago. So the camera technology 2 years ago were 40-pound machines. They were relatively expensive. So if you think about doing 5,000 exams inside the homes, that doesn't exist, right? Or even perhaps we're in labs where patients come in to get the A1C. Those are generally very small rooms, and I can't put a very large camera in there. But if I have something that weighs 2.3 pounds, is relatively small, I can put in a cabinet and it's space conscious. That's allowing us to bring that exam to, again, go where the diabetics are. And so you mentioned retail. We've seen a shift in the utilization of our platform, moving from primary care, which is one entity, to the health risk assessment. And these are organizations that payers contract to go close care gaps because they're incentivized for it. And most of those are taking place inside of homes. And then last but not least, to your point, we've started to see our retail segment of our business grow, where people are coming in for the pharmacy. But I think increasingly we're starting to see the brand awareness of our retail centers, like you mentioned, the Walmarts and so forth, and they are opening up healthcare centers as well. And they've got brand loyalty, and they've got pharmacies, and they are getting into that. And we are actually in screening programs in those entities here in the U.S. So I think that hopefully that answers your question, Varun.
No, it does.
Point. Also, I think it's a very important point about not needing to access different healthcare points for completing, let's say, your A1C, your retinopathy, and that's true in the developing nation context as well. Think about it. Even as in corporate screening, you pay a wellness package for diabetes management, include diabetic eye disease as part of it. Earlier, you wouldn't be able to have labs that would be able to do it because they wouldn't want to invest in something that is going to be simply a capital equipment that they look at. But now if they start investing in different business models, which can be either capital equipment, pay-per-use, usage-based, automatically now you can provide a wellness package that includes diabetic eye disease. So all of a sudden, you are able to get everything in one place rather than necessarily having to go to an ophthalmologist separately for doing that.
No, perfect. So I think what I wanted to maybe also round off this session with is, as I mentioned, today and tomorrow are innovation tracks. This is really followed by the investment and the ecosystem growth of startups and spotlighting companies. Yourselves, you've kind of gone through the entire journey of partnerships, collaborations, as you mentioned, the model of retail, the R&D that's already happened in the back. But what I did want to touch upon, which is quite unique, is you have a collaboration between India and the US with two very different models with companies in the same space, but relatively looking at innovations and in some sense, though around for some time at levels of a startup because of the amount of innovation and change of models happening year in, year out. If you could maybe touch upon how this collaboration came to be as a bit of an inspiration or advice on others in the ecosystem industry looking at following your footsteps to push innovation forward, and maybe how that may have helped push not only just the economic purposes of the businesses forward, but possibly driven further innovation for industry adoption? Because I think there's different stakeholders that have to be appeased, and some of them is stamp of approval and validation from medical specialists. And then of course the convenience and on the consumer side, which we've already touched upon, that has been done. So maybe just a key takeaway and wrapped around how your collaboration came to be.
Go ahead, Anand.
Maybe I'll go first. And so I think I always believe in the concept of centers of excellence, if you will. Oftentimes, and I think it's going to be extremely relevant, especially during a post-COVID environment where businesses may need to choose how do they actually grow, such that the growth is determined by choosing what the individual centers of excellence are when they think of partnerships. So for us, what was very clear when I remember when I went to the US looking at various options by which we could get our technologies there is, you look for someone who knows of course you would look for someone who knows the market. That's obviously a given. But what's more important is from the values by which Remedeo is driven is understanding your customer and creating a great customer experience, right? We here are creating a great customer experience by designing appropriate hardware. And what was extremely interesting to me when we were having conversations is the amount of emphasis that Iris had on ensuring the customer experience and the journey in terms of having a very high touch training program and things of that sort, because the options in front of us otherwise is we could possibly have gone through a distribution ecosystem, but then that doesn't work because at the end of the day, you know that this requires that work for this to succeed, right? It requires the training, it requires the ability to provide the support, and it requires the awareness to be raised. And so to that extent, I think we realized that that was the center of excellence that we could see in Iris, definitely that pulled us towards wanting to definitely collaborate with them. That's one. And the second is, I think to a large extent, if one were to look at businesses and business partnerships, I do believe that partnerships last when there is a significant dependence that each side has on the other as a result of their own successes, right? So we were very clear that our success and growth, therefore, could very well tie into Iris's, and similarly, Iris's would tie into ours. And therefore, it made for a great partnership because we are really complementing each other in terms of what we're doing and knowing where the centers of excellence are. So I'd possibly look at that as something that has led to where this collaboration has been. And I think it's going to be relevant for the industry as well. Definitely in a post-COVID environment where you would need to grow while keeping costs and excellence centers as what you determine by how you actually form these business models.
Yeah, I'll kind of expand on that. And I think Anand hit it right on the head. I was saying it's really easy to do partnerships and strike business development deals. It's really hard to make them successful for both parties. And I think, you know, there was and I think we also understood that there's the device, but then there's the interaction and the software and the uniqueness of the device. And Remedeo has always understood that. And it's software actually that really tightens that user experience. And they have been a really good development partner when we've said, look, we really need to make this a little bit more seamless and we've got to do some other things. And they've developed things, not necessarily on the device side, but on the software side to tighten that user experience. So that's the first thing about the business partnership. I think there's more we can do. Certainly diabetic retinopathy there's a lot of growth here because, you know, the market's only about 15% penetrated here in the US, but there are other eye care challenges that we can go solve. So my organization released an HIV retinopathy module, and we're now doing those screenings here in the US because HIV patients need 2 screens on an annualized basis. And I think that there's more that we can do. And as, you know, Remedeo develops more devices, I think we can put them on the platform and expand the utilization of and move beyond just that one disease state of diabetic retinopathy. So we've really enjoyed the partnership with Remitio and hope to even be larger here moving forward.
No, thank you for that. I think over the last few days, what has been clear is that the healthcare delivery model has gone from linear to multi-touch. And I think the pace of digitization has obviously increased. I think for yourselves and other innovative startups, innovative companies, people that we're looking at throughout the week, the one theme that I have noticed, and especially that will be obvious this week, is the companies that had started doing this before COVID were already thinking of the new paradigm, multi-touch, omni-channel, and that patient experience. You have a head start and a leap over others that are now having to think of patient experience being non-linear but multi-touch. And that's something that both of you have already obviously begun from some time ago. And it's great to hear that, and great to see, you know, how to make a partnership successful. So thank you for those insights. We sincerely appreciate you again being part of Medical Festival Asia, supporting Global Health Asia Pacific, and sharing these insights to the other entrepreneurs, startups, and the industry tuning in today. So thank you again for your time, and have a wonderful week ahead.
Thank you, Varun.
Thank you so much, Varun.
Take care. Have a good night.